Thank you, dear colleagues. I have to thank Dr. Sparias and the rest of the IGEA team for the kind invitation. They are long, we know these guys from a long time, and I see a lot of friends when I come here. And this is it's very nice for me to be here and present this very interesting topic. So we know that MR is highly prevalent and heterogeneous disease. It's approximately 8 to 10% in 75 years and older patients. Very heterogeneous disease from P2 prolapse type 2 in carpe diem to mixed A3 prolapse and MAC and restricted posterior leaflet. And we know that a lot of these patients are undertreated, and the expected mortality is a lot larger compared to the observed mortality in various studies. And you can see here is on the left with patients with reduced ejection fraction as opposed to the increased ejection fraction on the right. So there was a need chronically of new strategies to improve treatment and outcomes of MRs. And we know the answer to this. It was the TEER procedure. First in human TEER was performed in 2003, replicating the Alfieri stitch. And then we had the Everest 2 trial published in 2011, followed by the CE mark, and 3 years later we had the FDA approval. In 2018, Greg Stone presented in TCT the COAP trial, and there was a series of retrospective studies and case studies, all of them showing the efficacy and the safety of the procedure. And 3 years ago we had the FDA approval of the Pascal device, and we know now that it's an established procedure in certain categories of patients with primary and secondary MR, but there are expanded indications in MTEER as well, in cardiogenic shock and significant MR in patients with atrial functional MR, in patients with challenged anatomy, and this is an area that needs to be investigated more in order to have the best possible outcomes. We have the use from certain groups of MTEER in hypertrophic cardiomyopathy and trying to control the systolic anterior motion of mitral valve, and maybe the use of MTEER in moderate disease. And we know the guidelines regarding the functional MR according to after the COAPT and the MITRA FR. We have a class 2A indication after the optimization of good medical therapy. Regarding the degenerative disease, we have a class 1 indication for surgery, of course, which is the gold standard in this kind of patients, especially in the low risk. In high or prohibitive surgical risk, the TEER, according to the Everest 2 criteria, the studies 2A indication, or possibly in the near future for TMVR. And there are patients with intermediate surgical risk where surgery or TEER might be acceptable propositions, and this is the issue that is being studied by studies like Repair MR, which investigates these medium risk patients on whether mitral clip or surgical approach is the best solution. And what do they mean what do they look for in MR patients in a Repair MR? It's patients older than 75 years old, moderate risk, or if they are younger, to have an STS of more than 2. They should be symptomatic or asymptomatic with pulmonary hypertension, with end systolic diameter of more than 40 millimeters, or if they are younger, to have again these comorbidities. So we know that when we do a mitral clip procedure, we needed to have the best possible outcome to reduce significantly the mitral regurgitation, because if you have a severe grade 3 or 4 at the end of the TEER procedure, then you have almost 50% mortality rate at year, and this holds true also at 2 years for the COAPT study, where 73% of these patients had a mortality event. But there are mixed etiologies, like in of MR, and this is a relatively frail 82-year-old female with mixed etiology of MR. Recurrent hospitalization should be, it's a primary MR. You can have in this moderate risk patient a good outcome and reduction in symptoms. But we know that it's a steep learning curve in this procedure, so when you are aiming for optimal result, like it can be expected in more than 80% of the cases to have an MR or one or less in operators that have at least 150 cases under their belt. And of course, this is the learning curve changes. A lot of operators have now a lot more experience. There are a lot of educational conferences like this one. People are getting accustomed with the methodology, and also the devices are getting better. And we know that, and maybe Kostas, who was, and Dr. Chrysocheris, who were there from the beginning, they were using the mitral clip, the first generation, or the NT was better, I suppose, and the XT in generation 3 and the generation 4 with the new 4 clips. All this, and also by the optimization of the methods resulted in a better outcome. Now you can have more than 90% very good result, and this is evident in the expanded G4 study when we have where we have 92% of subjects achieving less than 1+ MR. And this stayed for the follow-up for 1 and 2 years. And if one compares the mitral clip therapy results with the EXPAND registry to historic studies like the Everest, the Realism, the difference is different. The difference is evident, and also if you can compare it with historical long-term data, you can see in all the studies you can have a good and durable result at long term. There are some comparison with MTR versus surgery, and one of the most recent is this France registry in a big cohort of 52,000 surgical MR repair or replacement compared to almost 5,000 TEER. The one-to-one propensity score matching showed identified more than 2,000 pairs. There was no difference in all-cause mortality in general cohort, but there was significant interaction with high-risk patients with a Euroscore of more than 4 favor in TEER with regards to mortality. And there is another smaller study comparing 700 MTEER with 123 minimally invasive procedure. The MR reduction with the surgical arm was better, but differences disappeared after matching in terms of mortality. We have the Matterhorn design, which was a comparison of MTEER with surgical mitral valve repair. There was a non-inferiority for efficacy, but MTEER was better in terms of safety. So in conclusion, mitral valve disease is undertreated. Only a minority of affected patients undergo mitral surgery. even when surgical treatment options are available, like in Western societies. The mitral clip procedure and the TEER procedure in general has been optimized the last decade due to the work of people like the ones that organize this very nice conference. But still, as we gain more and more experience, as we optimize the procedures, still we need to initially in the first cases, we need to aim for the green patients. We need to avoid the red patients, and there is a considerable amount of education that needs to be made for how better treating these patients in the yellow zone. And of course, this opens the discussion for the TMVR, which is another topic, and I think this will be investigated and will be discussed further in this conference. So thank you very much.
Thank you very much, Dr. Iakovou, for this excellent talk. Can we have 1 or 2 questions or a comment for 1 or 2 minutes? Anybody from the audience?
If nobody has from the audience, then I'd just like to make a comment on your slide about the learning curve. So the learning curve in TEER, mitral and tricuspid, you said steep. I would say very slow, because as you saw, it takes 50 cases just to understand and to separate, you know, from the beginner. And then at 150 cases, it appears that you are getting better, but as you saw, the curve kept going up. So I think these procedures...
Yeah, but after 150, it's stabilized.
Even 150, you'll get surprises. So I would say steep is the learning curve in TAVI, where if you have one valve with like 10, 15, 20 cases, you really go high up. But with TEER, SOS repair, I think it takes much longer, because the anatomy is much more complex, the leaflets, the orientation of your devices, how many devices, the anatomies are so different. But certainly, this is a trip that we have done over the past 15 years, and it's very rewarding to see that it's getting better, the results are getting better. It's both the experience and the training, but also the technological improvements in the devices. We're now in generation 5 of MitraClip. We'll go to generation 6. We're going to generation 3 of Pascal, later generation 4 of Pascal. So it's a field that moves so quickly, and it's very nice to see that we are getting
exactly, and as you saw that the results of the Matterhorn study. So you had if you have TEER in selected cases with very high procedural rates, then you have excellent results, much better than the COAPT. So this speaks for itself, I think. Yeah.
The M3, the advent of M3, will make us take all these red cases or the orange cases that sometimes now we are forced to do something, and they will go to a TMVR solution. So the better candidates, let's say, will stay for TEER. We have to customize like these therapies now that we're getting also a valve for mitral valve. So looking forward.
Okay, thank you, Dr. Iakovou.